I really love your facility, David. It's a godsend, I think, for a lot of people and a necessity.
Yeah, yeah, welcome. Thank you for having me on the show, Gianna.
That's no problem.
It's a
Well, this
honor.
is our first, masterclass for the year. So, you've got I guess the shoulders now have to bear the first one. So I know we're starting off
Yeah.
strong this year. So
Oh,
thank
geez,
you for
it's
coming
February already
on.
done. It's February already done. Gianna, you're not working hard enough. You should have had a couple of guests already.
Oh no. We definitely we work, all of us I think work way too much. But
No, and I
the
think
the reason sorry.
you've had some amazing guests. I've chimed into a few of them over the last year, and notable people, Peter McCulloch and other supporters and ambassadors. Just fantastic. You're doing absolutely wonderful things.
Yeah, we've got some, amazing people in the network and around the world. So we're very lucky to be able to bring such big brains and hearts together. But tonight's focus is on you, David. Now, David, you started off your career, what about, not that long ago, a couple of decades ago, and
Yeah,
you
well,
really built up a strong, profile as a neurosurgeon with your focus on brain and spinal health. And what's really interesting about you is that you're not when I say a typical surgeon, I'm saying you're not like a purist. You're not just focused just on surgery. That is part of what you offer. But what I really love about you and what I've gotten to know about you over the years is that you really walk your talk, and since I've known you, I've seen you grow. Your rehab centers growing. You give a lot of yourself, not only just in terms of the education, the medical education that you give, but also the papers that you've written, and also you're one of our board directors. So you're a busy man. But tonight we're talking about longevity and specifically how do we age with dignity? Because I remember not when I first met you, a couple of meetings ago, you mentioned to me that we should be living to 120 years old,
mm, mm,
and
mm, mm.
that's really stuck in my mind, and I've been contemplating that idea. How do you live to 120 years old and be healthy? So could you start off with that? Like what, and there was a term that you used, dying healthy.
Yes.
So
Yep.
what do you think that involves?
Yeah, well, I mean, that's a term that I coined, dying healthy, and it seems to be a bit ironic to say that. But when you think about your elderly relatives and friends or family or your parents, um, think about what their health was like in their last 10 to 20 years of life. And most people would think that as you get older, you'll naturally become afflicted with more disease, and that you'll die with disease, and that kind of doesn't really make sense to me. I think, of course, as you age, your functional capacity will decline, which is part of senescence, but senescence and degeneration per se are not really disease states. They are a natural part of aging, and we should be able to age with maintaining a high quality of life that meets the satisfaction of someone who is 80, 90, 100. Of course, I'm not saying that someone who's 100 is going to be able to do what they could do when they were 20, but someone who's 100 doesn't really want to be doing what they were doing when they were 20. But someone who is 100 couldn't be taking a bag full of medications and visiting the doctor in order to stay alive at the age of 100. And so if you focus on what I refer to as the those pillars of health most of your life, or if you're guided towards the pillars of health, then I think the natural process is that you should be able to die healthy. Okay, we all have an expiry date. That's, you know, this era of humanity. We can't stop the aging process, but I think we should be able to age healthily, and that we should be able to die healthy when our genetically predetermined um, time is up. And a lot of people not experiencing that in today's modern society. And that's really, I think that's a reflection of where modern medicine is going a little bit off the rails a bit. I'm not in any way being dismissive of the wonders and the marvels, the technology of modern medicine. Modern medicine. Every single week and every month, there's something new coming out from new technology, and it's just fantastic. But modern medicine is not very good. It's very good at preventing people from drowning in the disease states, but it's very bad at teaching people how to be good swimmers, so that they don't ever come close to drowning. And I think that's a really important concept of where medicine really needs to switch its focus. Like if you get hit by a truck and you need intensive care and you need trauma surgery and you need titanium rods to pull you back together, and all of this incredible stuff, modern medicine's got your back. But if you not eating well and not moving well and getting overweight and becoming hypertensive and having dyslipidemia and getting mood disturbance and lethargy, then modern medicine is highly likely to let you down in a very bad way until you start drowning, and then they'll try to salvage you. So until you need dialysis, or until you need a heart transplant, or until you need a coronary stent, and then all the bells and whistles of modern medicine come to the rescue. And I think that's something that I've realized working in neurosurgery, that we're kind of at the pointy end of the spear of medical technology, but we are generally very bad at teaching people how to not need that technology and those invasive procedures that we're very good at doing and that we've been trained to do for 20 years. And so I think that's kind of where the light bulb moment came for me. And the middle part of my, I think I'm coming towards the end of my clinical career now, and I want to focus on other things. But the first part of my career was just straight out of training, bang, 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 do as many symptom-based interventions as possible. Okay, so symptom-based interventions, fix people up. They're broken, fix them up. They've got tumors, fix them up. But I didn't spend a single second explaining to someone who had spinal instability, do you know why you've got spinal instability? Like, do you know why you're in pain? Do you know why your disc is herniated and giving you terrible sciatic symptoms so that you can't walk? That's where I really spend a lot more time now, focusing my attentions and my time, and that's where this centre sort of was born from. Was part of the primary prevention and trying to avoid using the scalpel.
It's really interesting how you raise those points about modern medicine. I love how you said, modern medicine is good at stopping people from drowning, but the next step in helping people to take more responsibility and prevent, its reoccurrence or actually stop. Because if you look at somebody, say, who's on high blood pressure tablets, they're told that they've got to be on high blood pressure tablets for the rest of their life, but there's never a discussion around how do we actually get you off high blood pressure.
Or why do they have high blood pressure in the first place?
Yeah,
they're not told why they have essential hypertension. What are you serious? Like, that's not really a satisfactory answer. And I think, that's why AMN, that's why I'm so honoured to be a part of AMN, is that really our mission statement is to provide this unbiased, unconflicted, fundamental empirical knowledge to the public about true health paradigms. And of course, if we are going to really improve the health of Australians, we have to address root causation. It's not appropriate, or it's futile to just keep trying to put out fires without putting the arsonist in jail.
Mm.
Like, it's crazy to say, just keep taking the blood pressure medications or pain medications or cholesterol lowering drugs without teaching them how to actually understand how to maintain health. And then most times you will eliminate the need for those medications and interventions because you restore health.
So I think you also mentioned about the significance of spinal health. Now, you go into like an aged care facility and you'll notice, a lot of, the elderly are, their faces are looking at the ground because their spines, their posture, their core, they've lost a lot of that strength in their bodies. How important is our spinal health on possibly living up to 120 years?
Well, these are the sort of, we can talk about that longevity being acquired through these, what I refer to as the four pillars of health. And they're interrelated. So it's not like, you got to have good musculoskeletal health. But the four pillars that I refer to are the movement quality, quality nutrition, quality sleep, and avoidance of unhealthy stress. Okay, a little bit of stress is okay. That drives us. It gets us moving every day. But repetitive unhealthy stress and worry, that obviously has a negative influence on your health. And also, those four pillars are really interrelated. So, if you address those factors, then you're on your way to being able to have that, high quality of life and longevity. So, my area of expertise professionally is spine, but the fundamental principles are no different, whether it's your knee, your hip, your shoulder. The most important thing that determines the health of those joints is the biomechanics associated with those joints. Okay, so we're talking about biomechanics here, and when we start to talk about biomechanics, we have to introduce a concept of skill. Okay, and when you introduce a concept of skill, you are now introducing a concept of coordination, because when it comes to the musculoskeletal system, skillful movement of the muscular system requires the central nervous system motor patterns, okay, our motor cortex and our cerebellum and all the other what we call the extrapyramidal parts of the central nervous system, the control movement. And you can see in people who have movement disorders like Parkinson's disease, they have poor coordination, they have poor control of movement, and of course they suffer significantly as a consequence of that. But when you walk through the shopping centre, or when you walk through your office and you see people moving in their everyday life activities, and I've done the research on this when it comes to the lumbar-pelvic spine, people move biomechanically terribly, absolutely terribly. 9 out of 10 people is what we showed in our study. And that was we did our study in a hospital. So, you've got people who are actually in hospital, and they weren't patients, they were staff members. They were workers. They weren't in the hospital because they were sick. They were in the hospital because they were working. And we did assessments on their movement through the day. And in terms of lumbopelvic movement, 9 out of 10 people move with poor biomechanical proficiency as defined by what I refer to as the movement points of performance of Neuro, which is our program that helps people restore that movement. So it really is no wonder to me that musculoskeletal health is one of the leading causes of disability in the country. Okay, and and that really parallels with metabolic health and obesity and diabetes and high blood pressure and other vascular diseases like cerebrovascular disease. They're very parallel in the etiology of the high prevalence of that. And the etiology is that people don't know why they have high blood pressure. They don't know why they have dyslipidemia. They don't know why they have diabetes. Like I'll give you an example. I saw a lady today who said that she's had diabetes for a long time and she's trying to lose weight because she's told that will help improve her diabetes. And I said, oh, that's great, wonderful. Losing weight does help you with diabetes. I bet you must be lowering your glucose intake. And she said, oh, no, I don't eat any junk food. I've never eaten junk food for a long time. I said, you mean you don't eat ice cream and you don't eat Mars bars and chocolates, right? So, no, never. And I said, so okay, that's interesting. So what do you have for breakfast? We have our Wheat Bix and we have our banana and we have our orange juice, right? And I said, well, did you ever think that may be one of the reasons as to why you have diabetes in the first place? That you're eating that. And she said, no, that's good for you. And so like this poor person's had diabetes for many, many years and no doubt seen many people about her diabetes. Yet she's never told that she's now intolerant to glucose, which is effectively what type 2 diabetes is, right? And if you said to someone, look, you're gluten intolerant or you're intolerant to peanuts, there's no way you're going to go near peanuts, or there's no way you're going to go near gluten. But yet there's, I don't know, 25% of the population are diabetic or pre-diabetic, and it's getting that way. I think the estimates are within the next 10 or 20 years, 50% of the population will be diabetic or pre-diabetic, which is terrifying, right? And yet the medical industry doesn't let people know that they are in effect, you could use the word allergic because patients understand the word allergic. They're intolerant. They are glucose intolerant. And no one wants them to even consider reducing glucose consumption. Okay, because heaven forbid that we cure all diabetes, it's totally conceivable. And you've got to then ask yourself, like, why? Like, what is driving this very poor fundamental empirical basic knowledge within our society? And I kept scratching my head about this. Surely people aren't that silly. The health industry, the dietitians, the NHMRC dietary guidelines, and then when you actually look into it, you just see it becomes very clear that there's this biased and conflicted information. There's just so much corporate influence over fundamental health policy. And it's almost like science has become a commercial product. Health and science has become politicized. It's a political weapon. NHMRC is getting money from various big food organizations. Big pharmaceuticals are coming into the fray and starting to have influence on medical education, on medical students, on dietary guidelines, and so it's almost like the corporate world has become a business partner with government. Okay. And whenever there's a business relationship happening, it opens up the opportunity for conflicts of interest and corruption. And and so now you got to say, well, why did this patient not know that? Like, and where is her information coming from when she wakes up in the morning and watches TV, or when she reads the newspaper, or most people will turn on their phone and they'll have a feed of some sort. What is controlling the information that hits her eyeballs? And there is just so much information out there that in some ways you could say that the information superhighway is wonderful, which it is, but this is another concept, that anything that is so powerfully wonderful like that also has a dark side. It's like
David,
Star Wars.
you've touched on glucose, which I think is really important, and it'd be really good if we could expand on that from a nutrition base. So,
So we
we
focus
are
on the
to have
metabolic
a,
pillar.
if we're to have a long and healthy life,
Hmm.
what foods, nutrition, what does that look like? What sort of diet does that look like? Just from a nutritional point of view. So
Okay,
low glucose, so no chocolate, no ice cream ever. Like what are we talking here?
no, absolutely not. So it depends. Everything has to be put into context. Okay, context is so important. Um, uh, so like, do I ever have sweets? Of course I have sweets, right? Do I ever have chips or a milkshake? Yes, I do. Um, but you've got to remember that I'm not using nutrition as a medicine because I don't suffer from diabetes or obesity or high blood pressure. I'll tell you that I used to. I absolutely used to. Not to. If I was doing a slideshow, I'd show some slides of myself. They're pretty embarrassing slides. I've done a few other talks, and I've got a slide of myself. And seriously, I was puffy. I had a double chin. I was size XL. And here's someone who thinks they're healthy, who thinks they understand how to be healthy as a specialist in medicine, but just completely railroaded by the information superhighway, right? That is controlled not by people who want to keep you healthy, but it's controlled by people who want to make money. Um, so what did I do? I just went back to Guyton's textbook of physiology. Okay, Luke, you'll remember that one. We bought that in our first year of medicine, and it was just my favorite book. But even chapter 1, I'd just forgotten the basic fundamentals. When you consume glucose, your body, the islet cells of your pancreas release insulin. Okay. Now, if you keep uh, consuming excessive amounts of glucose, then your islet cells have to keep secreting more and more insulin. Okay, so there was a time when people used to say, "Oh, you've got to have 7 or 8 meals a day," and then that was the teaching, and breakfast is the most important meal of the day, and your fruit and veggies, an apple a day keeps the doctor away. So these are popular culture dogma that has absolutely no scientific validity at all. And it's just turning people into people who are afflicted by a condition which we refer to as insulin resistance. Insulin resistance. Okay, so your question, what is the diet that you should adopt? And I refer to it as the LIFE diet, LIFE, and I coined that because it stands for low insulinemic food for everyone. Okay, low insulin. Now, so if you do have a metabolic condition that's related to insulin resistance, then you need to use that diet as your medicine, as your medication, and you need to be very strict with that diet. Okay, so in that circumstance, you do not have ice cream and hamburgers and chips and rice and potatoes, which are very high in glucose, because you're using the food as a medicine. No different to if you were given an antibiotic for pneumonia. You would be very strict with that antibiotic. Okay, doctor says you've got to take it 3 times a day, 500 milligrams of amoxil. You're not going to go, oh, I'll skip today. I'll wait till lunchtime to have the antibiotic. I'll skip the morning dose, because you're using that tablet as a medicine for a condition. So when you have disease, when you do have insulin resistance, you do need to be very strict with your diet, and that means really cutting back glucose. And yeah, even now, I would probably have 5 to 10 grams of glucose per day. Like my whole day today, I probably had less than 5 grams of glucose. Okay, so one slice of bread has about 10 to 15 grams of glucose.
Oh, okay.
A potato probably has, you know, 10 to 15 grams, or maybe more, probably 30 to 40 grams in a potato. So remember, one teaspoon of sugar is 5 grams, approximately 5 grams of glucose. So really, and people always say, oh, but you need glucose to keep your brain ticking. Well, that's obviously not true. I've just done a 1 hour workout and had no glucose effectively all day, and I'm sitting here talking to you. My blood sugar is probably like 2.5, 3, and I feel absolutely fine. So there's lots of misinformation in regards to glucose metabolism.
What
So
else, David? What else do we need to completely avoid?
Well, once the person gets their insulin sensitivity back again, which is exactly what happens, right? So the patient that I was talking about, I said to her, when you start to say have bacon and eggs for breakfast, if you want to have breakfast, which has 0 glucose in it, guess what you're going to have to do? Your blood sugar is going to come down. Okay, so you will have to reduce the dosages of your oral hypoglycemics, because you won't need to take those tablets because you're not consuming glucose. And so what does that mean? Oh, she said, if I don't need my tablets, does that mean I'm getting better? Does that mean I'm curing my diabetes? Yes. So if you don't need your diabetes medications, guess what you've done? You've just cured your diabetes through your diet. Okay. And what she is allowed to do then is that she can then start to reintroduce a bit of glucose, because she's reestablished some glucose sensitivity, some insulin sensitivity. So once you reestablish that insulin sensitivity, yes, you can have some glucose. You can indulge. You can have a pasta or whatever it is that you love having, which is high in glucose. And that sort of reflects what we all understand as the 80-20 rule, right? 80-20. If you're good 80% of the time, 20% of the time is not going to hurt you. But the 80-20 rule, or the scientific term for that, is the Pareto principle, or the Pareto's law. That really only applies from a position of health. If you're in a position of disease, the Pareto principle does not apply. You have to apply the 100-100 rule. Earn the privilege to apply the Pareto principle. So your question, do I have some glucose? Do I have some confectionery? Absolutely, I do, but I'm not going to break the Pareto principle, and otherwise I'll get sick, like I was before, and then I'll have to go back to the 100-100 rule.
That's great. I've never heard of the 100-100. So you mentioned that, health has been corporatized, and especially, whilst we're on the topic of food has been, pretty much it's controlled by corporations. So how do we change that, David? How do we make this, even if it's a small step, how do we actually change this? Because a lot of people out there love what you're talking about, and it's very simple. It's a very simple approach to
so simple. Nothing.
So how do we actually do it?
I don't talk anything overly technical and to my patients. There's no point. They won't understand much more. Even when you start talking about insulin and glucose, that's about as deep as you need to go with them. But it's so simple in the fundamental concepts, and that's another thing. The more you go into empirical science and fundamental science, the simpler it gets, and the more precise you are with your understanding of a concept, the more precise you are understanding the empirical things that make up that somewhat complex problem. And so when you're explaining root cause to people, it's actually really easy because you've gone back to the bare nuts and bolts, right? But to answer your question, I used to think that I was just sitting in an office alone, one-on-one with patients, right? And then we now have platforms like AMN to educate more people, and we would hold community seminars. We've held a few seminars over the years, and we can fill the room with 150 people. But that's the way it's got to happen. A friend of mine called Gary Fetke told me this a long time ago, and he said that it's the only way that we're going to affect change is through a grassroots bottom up approach. And that means educating the masses, and that's everyone who's listening to you, Diana, on your podcast, and obviously organisations like AMN. We can have much broader reach. I can talk to 15 people a day in my office, even though they might come to me about their spine pain. I'll sort of sneak in there a little bit about their metabolism. But when we have organisations like AMN with fantastic people who are passionate about these very simple messages, which is great because everyone can do it. Every doctor can do it. You don't have to be a specialist. You don't have to be an endocrinologist. You don't have to be a PhD biochemist or nutritionist. Like it's in chapter 1 of Guyton. So if you got through your med school, if you're going to understand these concepts. And that's all patients need, is they need these basic fundamental root causation empirical concepts. We can then start to change the policy that our government is putting forward that is currently not working. We know it's not working. Like, look at the statistics. And we keep forgetting that, the government is not our boss, right? We are their boss. So the more people that understand these concepts and the more people that demand better nutrition panels, better taxes on whatever harmful products that we might buy in the supermarket, the more likely policies will change, because your local politician doesn't want to get voted out at the next election, right? So they will start to develop voting platforms based on what the community want. And it's our job. That's what I see our mission is as AMN, as a director of AMN. Our mission statement is to have that grassroots health, unconflicted, unbiased health education of the public, and it just permeates. It's just like once you hit that, what do they call it, the tipping point, where the information just goes viral. Okay, and you can see, even I think industry will start to cave to that. Like, it has a little bit, like, we have low carb beer and we have things like that where did low carb beer come from? I wonder why they did that. Well, because we started to talk about carbohydrates a bit more and how harmful they were. So industry goes and makes a low carb beer. But it just needs to happen on a much more mass scale. And that's how we affect change. That's how we reverse chronic disease, which is 90% of the workload of the country. We could shut down hospitals.
It's an exciting area to be in, because there's so much hope and work to do. How much of this do you think genetics plays into it? Because is there, can we alter our health? Because if we're genetically disposed to, certain, I guess, conditions or potential conditions, how do we in effect stop that? Is it through the exact same approach, like you said, the 100-100 principle? How do we do that?
or, there are people who may have genetically predisposed metabolic conditions, and, for example, you've got type 1 diabetes. Okay, so type 1 diabetes, it's a shame that we even called it diabetes. They're sort of two very different diseases. One is insulin resistance, and one is not producing enough insulin. So it's crazy. But say, for example, there's a friend of mine whose name is Troy Stapleton. He's a radiologist. He's got type 1 diabetes, and like when he got diagnosed, no one told him about reducing glucose consumption as a type 1 diabetic. And he, of course, was able to go back, like myself, go back to the empirical science and just work it out. Like if I'm not making enough insulin, I need to inject myself with insulin. Well, I can reduce the amount of injectable insulin if I don't eat as much glucose. And bingo, he basically cured his type 1 diabetes, or he only needs basal amounts of insulin, which is what we all need. We just need basal amounts of insulin to stop diabetic ketoacidosis. And so there's an example of someone who's got a genetic condition that is also managing it with lifestyle. And it's just it just makes so much sense. But like, my wife's got a genetic condition with her kidneys. And, we've been through renal clinics and multiple renal physicians just talking, just checkups and whatnot. And and one of the effects of kidney disease is high blood pressure, and that's because the kidneys are shutting down. And so a consequence of that is hypertension. And so she's quite strict with nutritional ketosis. She really keeps a tight control of her ketones through her diet. And not once has a renal physician suggested that that's a good idea. And in fact, some of them have actually said, no, that's a bad idea. Because when you go adopt a nutritional ketosis dietary lifestyle, you're kind of eating a lot of fat. You're eating a lot of natural fats, healthy animal fats, flesh, meat, and fat. And so, no, you couldn't possibly do that, because if you do that, your cholesterol will go up, right? And so even though the blood pressure is really well controlled, at her age, and compared to other people with the same sort of age and conditions who are on dialysis and all sorts of horrible things, she's just adopting a nutritional ketosis dietary lifestyle and healthy as. And yet the experts are sort of, I'm just a bit worried about this. And so it's just, you really you just walk out of there scratching your head, like, why do I even come to these clinics? Like it's a genetic predisposed condition. And so, there may be a time when my wife's renal function deteriorates beyond a certain point where she may need modern technology to step in with whiz bang, dialysis machines or renal transplants. And we're very grateful that modern technology can do that and save people's lives. But remember, we're talking about the 90%. So when you ask about genetic diseases, that's 1 out of 10 or less. We're talking about 9 out of 10 people that are suffering from diseases unnecessarily, that are entirely 100% preventable. And then musculoskeletal. So musculoskeletal. Yeah. That's such a
David, there's a lot of technology also being pushed into, medicine in this space of longevity and, extending lives. What are your thoughts on things like, these AI tools that come out and, even I guess there are all sorts of like stem cells. What do you think about, the future? Where are we going? Okay, we've got 9 out of 10, 50% of people are going to be diabetic. Those who are serious about this, how do they, what do we need to focus on? Because a lot of these
Well, I
things
think,
can be very expensive.
yeah, they're massively expensive. In some way or another, as taxpayers, in democratic society, we are all paying for it, and the health budget is a massive proportion um, of taxpayers' dollar. I can't remember the exact, but it's something around like 5% or something like of every dollar we spend is spent on health, or it might be more. Um, but you've got to go with the low-hanging fruit, right? Go with the easy, cheap stuff. And I think if if you did that, there's a lot of the pressures, for the expensive, highfalutin stuff would kind of diminish, and people would go, well, do we really need to spend $1 billion on a startup company that's going to work on stem cells,
Mm.
for disc replacements, or to inject into someone's lumbar disc because they've got back pain? And people are doing that. People are doing stem cell research on injecting stem cells into the spinal discs because their discs have accelerated wear and tear, okay,
Yeah.
accelerated wear or degeneration. And so it kind of makes sense. Like, if you can restore that disc health with stem cell technology, then that kind of makes sense. But I can assure you that before anyone gets a liver transplant because they've got cirrhosis from alcohol consumption, they would need to stop drinking alcohol.
Mm.
Right. So you're not going to get a liver transplant if you're still drinking alcohol. You're not going to get a lung transplant if you're still smoking cigarettes. So why should you get stem cells into your lumbar disc if you're still moving biomechanically poorly? Because it's only going to fail. Okay, as a fundamental principle, if you only address the symptoms and you don't eliminate the reason why the disc became accelerated in its degeneration first, you can have the most fancy technologically advanced stem cell therapy into your disc, and it ain't going to work. Okay, so
Mm.
there's another $1 billion of money gone down the gurgler.
Mm.
Um, uh,
With respects to biomechanical movement, what do you think each one of us should be doing to be at our optimal best? Like every day, what should we be doing?
well, in relation to your lumbar pelvic spine, there's some fairly, and again, it comes down to context. Okay, so if you have a lot of spinal pain, then um, going back to the 80-20 rule, right? You actually need to use the 100-100 rule. If you don't have spinal pain, then you've by definition shown me that you have stable motion segments in your lumbar spine, or your cervical spine and your thoracic spine. But your lumbar spine is particularly vulnerable because of its location in between two centers of mass. You've got the center of mass of your torso, and you've got the center of mass of your pelvis. And effectively, you've got 5 vertebrae that stick up between these two centers of mass. And so when you move poorly, those 5 segments, L5, L1, 2, 3, 4, 5, and the sacrum, are very vulnerable to poor movement quality. And it's unique to modern industrialized societies, this poor movement. If you go into rural parts of China, and I've been there, and Africa, the movement proficiency is beautiful from infancy through to elderly. It doesn't get corrupted. But when you live in modern industrialized lifestyles like we do, like we've been sitting here now for nearly an hour, that is modern society behaving like a domestic cage on us as humans. Okay, and so that modern societal influence corrupts movement proficiency. Okay, and you would not expect to go out into a jungle and see a bird flapping its wings in some weird way, right? Because they live in their natural, normal environment. And we've made the modern world our natural environment. So we are not moving the way we're designed to move. If you went to a zoo and saw an animal caged up in a small cage, you might actually see some dysfunctional movement in that caged animal because it's not meant to be there. And we can observe the same in humans. And so what happens is people start to lose that natural motor coordination that you can see. Anyone who's got a toddler, you watch a toddler, and I've got some gorgeous little nephews, Thomas and Arthur, and I watched them. I went to their house not too long ago, and I was watching them playing, and they just like they haven't done my course. They haven't done my movement therapy 6-week course, right? and they move beautifully. They express all the movement points of performance that we kind of teach here. But when I see my patients in clinic who are afflicted with chronic back pain, they all fail. They all fail just out on every movement point of performance. And so, and I hope little Thomas and Arthur move well. Their dad's a very keen athlete and functional athlete, so he's going to make sure that they continue to squat well, deadlift well, run well, walk well, sit well. And if we do that, that's basically just getting out of this domestic cage that society is putting influence on us. And that's why. So that's what your question. The term is functional movement, and there are a couple of biomechanical movement points of performance that you want to adhere to. You want, in terms of your lumbar spine, you want posterior chain activated movement. You want hip centric rotation. You want neutral spine awareness and maintenance. You want unloaded knee positions when you are inclining your torso, and you want proficiency limited intensity. So that means everything you do has to be limited by the expression of the aforementioned quality movement biomechanical principles. Okay, so if something is too heavy for me to do and it's going to make me break those principles, it's going to make me round my back a little bit, then that means I don't lift that thing that's too heavy. If something is too hard for me to pick up on the ground because I don't have the proficiency to pick up a 5-cent coin off the ground, I'm sorry, you can't pick that 5-cent coin up off the ground at the moment, right? Doesn't mean it's going to be like that all the time, because as we continue to express those points of performance that I mentioned, your musculoskeletal segments will get better. Your tendons will get better. Your muscles will get better. Your joints will get healthier. And of course, that's associated with less pain. And then your proficiency limited intensity improves. So after 2 months, guess what you're doing? You can lift something a little bit heavier. You can lift something closer to the ground. And eventually, and that's what we see in our patients, is that once they're moving well, they are restoring quality of life. Their quality of life returns because their functional capacity has gone up. Okay, so functional capacity goes up with expression of movement proficiency.
So do you recommend that we engage, a center like what you've got, or exercise physiologists, like how do we, because you can watch it on YouTube, you can do, but if you don't have the right techniques, you can hurt yourself. So how do you go about starting?
It's a skill that requires hard work. Okay, and I think currently the industry is a little bit of a sausage factory. How many patients can we see and how quickly can we see them, and what's the lowest level of effort that I need to put in to be able to swipe that private health card. And that's a good business model, but the outcomes are terrible. Okay, and then you say, well, show me why they're. Look at the statistics. The rates of back pain actually have got worse over the last few years. They're not improving at all. They're actually getting worse. And just drive around your suburbs. There's a physiotherapy studio. There's a chiropractic studio. There's a gym almost on every street corner. Okay, so it's not that there's no services for people in the physical therapy arena. It's just that the quality of the service that's being delivered is suboptimal, and it's not focusing on biomechanics to the degree that it needs to. And again, it just comes back down to demand from the public. If the public starts to realize, hey, I've got to start getting better at my. I heard this guy talking about biomechanics, and when I went to my therapist, he gave me a massage. He gave me deep tissue release. He gave me some stretches, and I was on the couch for the whole 30 minutes. I didn't actually focus on biomechanics for 1 second. All right. So that's why I say to the therapists who want to help people with back pain, throw away your couch. Throw away your couch. Your couch, you can do your examination on your couch, but once you've done your examination, throw it away. It's not part of therapy. You
Mm.
know, massage is not a therapy. Just don't even use the words massage therapy. I'm sorry if anyone's a massage therapist there listening, but it's a beautiful thing to have. I love having a massage, but I have a massage when I go to Fiji and I'm on the beach. Okay, I'm on the beach or I'm in Hawaii and I'm relaxing. That's when I have a massage. I don't use massage as a therapy when I've got a ruptured disc. It's
Mm.
not going to work because that won't help your biomechanics. By all means, give massage for some symptom relief,
Yeah.
but at the same session, give them 10 minutes of massage and then 20 minutes of biomechanics. Okay. Give them some Pilates and then give them some biomechanics. Give them some acupuncture, then give them some biomechanics. That's what we need to do. If acupuncture is your business model and that's how you make money and pay off your house, that's fine. But also give them some biomechanical movement therapy in the same, put some more emphasis on that. And if you look at the guidelines on the government sponsored quality care in back pain management. It's I can't remember the website. The quality care standards. There is not one word, not one sentence that talks about biomechanics. Okay? And that is a massive failing. And the people who were involved in writing that guideline policy, that students and clinicians and doctors and patients will possibly come across on the government.gov website should be absolutely ashamed.
Mm.
It is disgusting. It is disgusting when spine related pain, which is a stack of joints stuck up on top of each other. The most important thing that influences their health is the biomechanics associated with those joints. And if you set out to make guidelines that ignore that completely, and you're a professor of physiotherapy or whatever you may be, you should be absolutely ashamed.
Mm. I've come to learn how important your spine is because you've got the nerves, you've got the ligaments, and they're all attached to organs and
Yeah,
tissues,
yeah,
so they all
yeah.
relate to one another.
And that's why back pain is so debilitating because in our central nervous system we prioritize areas that the brain knows are important, things like your eye and your mouth and your fingers. So like if you get a something in your eye, it could be a tiny piece of sand, right? And like you feel terrible, like I just can't, because your brain over represents the importance of your eyeballs to your survival. Okay, so when it comes to the spine, the brain interprets the spine as this very critically important joint or system of joints, because living inside the spine, which is unique to any other joint, is the spinal cord or very important nerves, right? So it's a little bit like the eye being so important. The brain, even if it's just a little joint pain, let's just say it's a little strain to your disc, which is absolutely nothing near the nerve, right? It's just, but the brain interprets that as, oh, this is a threat to the spinal cord. And so it just locks you down and stops you in your tracks, and that's what people talk about. I got this sharp, severe pain and it just floored me to the ground. I had to call the ambulance. And I went to the emergency department. They gave me some morphine, put me in the scanner, and I said, everything's normal. Okay.
Mm.
And then they sent me home. That's the paradigm that we're currently operating in. But that's far from normal. That's a very, very important red flag that says, hey, your biomechanics are terrible. Okay, you need to fix them. Otherwise, guess what's going to happen? You're going to get another flare up. You're going to get another episode of pain, and that's what we know is happening. When you get an episode of back pain, 70% will recover within 6 weeks, but 30 to 40% you'll get another episode within 12 months. Okay, and the more episodes you have, the more likely it is that it will not recover. And then when it doesn't recover, you now are defined as having persistent low back pain or chronic pain. And then a whole host of new neurophysiological maladaptations occur. And that becomes even more challenging to fix because it's like a wedding cake, right? There's layer upon layer upon layer, and the longer you leave it, the more problems develop, and all of them become just as challenging to manage and confuse the picture. And then, of course, you get depressed and anxious. And guess what they do? Guess what the industry does? They said, "Oh, you've got back pain because you're depressed," right? And then they say you've got to go and get cognitive therapy. So now we've completely moved it out of a musculoskeletal problem into a psychological problem. And so they want they want physical therapists who have gone through university learning about joints and muscles and tendons and ligaments. They now want them to become counselors for these people with chronic debilitating back pain. And then, even worse, they say, I know you're in terrible pain and you need your opioids. And we've talked about this, Liana. We're not going to let you have your opioids now because there's an opioid crisis. Okay. Now that, and I'm sure there's lots of people out there, I engage with them quite regularly on social media. It's cruel. I'm not disputing that opioids have terrible side effects, but to say there's an opioid crisis and not say that we have a crisis of rehabilitation, we have a crisis of effective rehabilitation in the same breath, then you are misleading the public. Because the opioid crisis is not an opioid crisis because of opioids. It's an opioid crisis because we have a crisis of terrible musculoskeletal care.
Yeah.
And that we just need to start being honest. We just need to start being honest with people and start delivering fundamental cause-based therapies. And the chronic disease will just disappear. I don't know whether it'll happen in my lifetime or not, but hopefully, AMN will be a big part of that as time goes on and as we build our subscribership and people. I know there's wonderful people out there that just have heard stuff that you've said and that I've said, and they start telling their friends and their neighbors and their network, and we'll just get that critical mass. We'll just get that critical mass, and that's when then the pharmaceutical industries that are just reaping the billions and trillions of dollars of benefit from chronic disease will just shut them down.
And that's so true, because they can come to us and get a very balanced view on what to do and an honest view. It's not being funded by anything.
Yeah, we're
David,
here because we want to be here.
Before I go on,
I'm not getting paid to be here. We're here because we want to be here.
I know you're not. That's why, we love you so much, because you actually care. And I remember you said to me, I want to help as many people as possible. And that's, what we share in common. But I want to now allow our lovely, lovely, lovely guests, our other guests, to be able to maybe ask you some questions, because, they're not going to have access to you because you're a very busy man. So
you can call me anytime. I always answer emails.
Yeah. If anybody has a question or wants to add to something that David said, raise your hand, and we'd love to hear from you, because we've got some great minds here. So please say something. But while we wait, because it takes a while for someone to put their hand up first, David. So
from Julie something.
Yes. Julie, she's a patient of yours. So she said that she's very grateful for her surgery, that you've basically, she's in no pain.
Oh, thank you so much for that, Julie. That's wonderful. You did all the work. The surgery is the easy bit. Anyone can do the surgery. It's the hard work afterwards. That's where all the goodness happens.
So David, where to now for you? You know, you've hit, you're a well-respected surgeon. Like what's next for you? What do you see yourself, where do you see yourself going?
I think you lovely to say those type of things. I think I'm probably seen as a bit of an outsider. I'm, a bit on the fringe. I sort of regularly talk about these concepts with my colleagues at meetings, and I think for the larger part, people are happier to just keep plugging away, doing the fusions, doing the decompressions, um, doing the operations to sort of help the downstream problems. But I think just imagine a patient who's listening to this going to their spinal surgeon next week and saying, can you send me to a functional movement therapist? And they go, oh, geez, what's that? I haven't heard of that. And they say, have you heard of Dr. Johnson, or have you heard of functional movement therapy? That's when, you just have to, it's like supply and demand, or the demand drives activity. And the more people that know about these basic principles, the more the industry, including spinal surgeons, will say, okay, right, I'm not going to send you to the local Pilates studio. You've been doing hydrotherapy for 10 years. It's not working. I'll maybe we should try something different. Maybe the way the joint moves is important. And it'll be like a little light bulb moment. And that's all it takes. Okay. And I don't know.
There's a
There's a
question
couple of
here. Oh,
yeah.
sorry, David, keep going.
No, I do have some colleagues that regularly refer their patients for this type of approach. So that's wonderful. But there's
We've got
there's
a,
40
we've got a,
40 spinal surgeons in Queensland.
we've got a question here. Is there a functional movement therapist that you know of that's like you in each state?
We are absolutely working on that.
Yeah.
We have fantastic affiliates, North Coast. We've got a fantastic fellow in Sydney. We're about to train a fellow from Melbourne. There's a fellow in Perth that's been in communication. So look, it's growing, and these guys are going to lead the way. I really think these guys are going to lead the way, and um, like I said, once other services start realizing that they're losing clients because of fantastic outcomes elsewhere, they'll go, look, I need to learn this as well. But yeah, so it's growing at the moment. Obviously, Brisbane is my headquarters. Sunshine Coast. I haven't really got anyone on the Gold Coast at the moment that's delivering functional movement therapy. But there's a lady who contacted us not too long ago who's expressed interest, and they do come from all walks of life. Some of them are physiotherapists, some of them are exercise physiologists, some of them occupational therapists, some of them are personal trainers. You do not have to have PhDs and a whole bunch of letters after your name. You just need to be a human being that knows how to move well and knows how to transfer those skills of movement to someone else. And that's not always easy, right? Like, think about teaching someone how to play golf. If you wanted to teach someone how to hit a golf ball, how long it would take and how patient you'd have to be, because they might hit the golf ball terribly for 100 times, a whole bucket of golf balls. It's just been terrible after it. But with patience and good cueing and skillful coaching, you eventually get that person to hit a beautiful drive straight down the fairway, right? That's a wonderful feeling. And it's everyone's effectively capable of doing that. But it does take a lot of dedication, both from the therapist and from the patient, which is why I said it's a difficult business model that only can be successful with the economy of scale.
Yeah. You're very busy. You're a very busy individual. So this next question ties up with that. how do you handle sleep and healthy stress? So what are your pointers around that?
Ah, you got me, Deanna. You got
Scream
me.
at people?
You got me. Oh, look, you know, um, stress is one of those things that I've kind of just, I have, I think, and anyone going through specialty training, Luke, it's a hard grind and it's stressful, and you go days. I've been 3 days without sleep,
That's
and
why I
I'm not
asked you
sure.
the question, David.
Oh, is that for
Yeah,
you, Luke? Oh, you
yeah,
bugger.
I thought you might have some pointers.
Well, look, my physicality is a priority. Like that's one certainly. Uh, Absolutely, I place it, on par with my family relationships, my physical training, um,
Mm.
and time with family, because without that physicality, you can you just lose that natural endogenous hormones and de-stressing hormones that allows you to reset. Um, and so, people say, oh, but I don't have time to train. I don't have time to go for a jog. That just means that you're not placing it high enough in your priority list. So if I asked you, like, when was the last time you went to the gym?
Mm.
Oh,
Yeah.
to be honest.
Yeah.
Yeah,
So
no,
like, I
years.
mean, and
Yes,
so like but you might have other ways of de-stressing, right?
yes,
And
I do.
you might go fishing, or you might go listen to some live music or something like that. As long as you've got something, as long as you've got that outlet that has that effect on you mentally, that and you prioritize it, or you might say, oh, no, I'm too busy to go fishing this weekend, and that just gets put off and put off and put off. But for me, it has to be every day, and it has to be in that little dose of that 1 hour a day. Oh, I've got a cup here. I don't know, that just come. Got a cup here. It says the best
Best
hour of your
hour.
day. Okay.
Mm.
So for me, it's that if that's like my reset pill, and coming here is my reset pill. And honestly, I could come here incredibly stressed from a terrible day, feeling absolutely rotten. And at the end of my training with my community, with my friends, I just feel on top of the world. And that's physiological. That's just pure test tube chemistry, physiology, that my brain has released endogenous opioids, adrenaline, dopamine, cortisol, all of the amazing things that just drive health back into me. It is still a balance. Like, I'm not saying that I'm going to live to 100, but that's what I need to do to try to optimize the impacts on my life that are sort of
How do you
negative.
balance then, like if you're, and Pip, we'll get to you next. Thanks for waiting. How do you balance? So if you are actively working out every day and your body craves it, right? But then how do you balance the brain where if you don't work out, you start to feel bad, and then you start, having, negative conversations and beliefs about it.
Mm,
How do you maintain a
mhm.
healthy belief system around working out? Because that can also become counterproductive too.
Yeah, I mean, that's where my wife helps me. And my wife says, David, go to the gym. Go, go and train, you idiot. You're annoying me. Go and train. So, yeah, that's absolutely true. For whatever reason, if if I miss a couple of days in a row, actually, when I go on holidays, when we used to travel, we haven't traveled for 4 years now, but when we used to travel and we go overseas, um, I that was one of the worst things about going on holidays. If we went to Hawaii or we went to America and New York, and you kind of like doing all these holiday things, and uh, and there's just there is no time in your schedule, literally no time in your schedule to go to train. Um, it would really create a negative mindset. I wouldn't
Yeah.
like it. And so I'd do crazy things like run up and down the hallway of the hotel and do handstand push-ups and burpees and squats and, you know, those sort of things to sort of try to make, but it didn't quite hit it, you know. And
There's
it was
still
eventually
something.
but we then ended up actually choosing our holiday destinations and our hotels based on their gymnasium. It wasn't based on their the location or the, you know, the restaurants, or it was like, oh, I want the before we book that, just go and get the concierge to go and do a video of the gym and show me the gym before we book it.
Oh, we'll go to Pip. Pip, thanks for waiting patiently.
Oh, no trouble at all. Can you hear me okay?
I can hear you, Pip. Yeah.
Yeah, hi David. Thanks so much. I'm Pip. I'm in Tassie. And I've just got a question. I've got a new friend who's in his late 70s, and he's been a type 1 diabetes, if you don't mind me just going back to that, for about 40 years. And has had some cognitive decline post his COVID injections and anxiety as well. And he's become fixated on the blood sugar numbers. He has a monitoring device so he can see it at any time of the day. And he likes to keep it up around 19, gets quite stressed if it gets lower. And do you have any sort of tips that might be helpful to help him realise that that's not a healthy blood sugar range?
He's happy with his blood sugar around 9 to 10.
19.
19?
19. He gets very stressed if it gets down as low as 10, and he eats stuff to try and increase it.
It sounds like he may have had some like hypos in the past, has he? And
Quite possibly, yes, and is scared of letting it go lower.
There are specialist endocrinologists that understand low carb management of type 1 diabetes as well. I strongly recommend he touch base with a doctor called Dr. Kevin Lee. He's an endocrinologist, you know, that's his craft. And he would probably be able to do a video consult or a Zoom type telephone consult. And, you know, just to give him a bit of guidance as to, you know, what targets he should be looking for. Type 1 diabetes, you do have to be very careful, because if you do adopt a low carb diet, you've got to be very careful with the titration of the insulin levels and what levels of insulin will push someone into ketoacidosis, because, you know, that's terribly and acutely dangerous. So look, I wouldn't want to give too much advice in this setting for you to convey on to him, other than to say, look, you know, the complications of diabetes are related to two things. Obviously, how well your blood sugar is controlled and how much insulin you need. If you're using a lot of insulin, to control your diabetes, then that's a very harmful effect for the chronic complications. And then if you're using if your blood sugars are very high, then you're glycating, you're plastering glucose molecules over all of your proteins, which of course is terrible as well. You know, that's part of the reason why we get the terribly high and unhealthy lipoproteins, the so-called LDLs, so the so-called bad cholesterol, which there is no such thing. There's no bad cholesterol. It's the bad carrier proteins. Not the cholesterol itself, which is an absolute misconception. That is.
Well, another one with ranges aren't in the right place, are they, on the guidance? Yeah.
It's a glycated ApoB receptor on the LDL particle that can't get taken back up into the liver circulation, the liver cell, and then pushed into the endothelium, and the next minute you've got a plaque. It's got nothing to do with the cholesterol. It's got everything to do with the glycation of the lipoprotein carrier molecules. You know, it's so basic that you just spend 5 minutes with your patient and they understand it. You know, But
Thanks.
yeah,
Yeah,
look,
thank you.
talk to Kevin Lee. Kevin Lee, if you have any difficulty getting in touch with him, get in
Mhm.
touch with Deanna, and she'll hound me to give you Kevin
Yeah.
Lee's
Okay,
contact details. Yeah, he's great.
thank you. What state's he in?
He's in Brisbane. He's in
Is
Brisbane.
he? Yeah. Okay, lovely. Thanks so much.
Thank you, Pip. Garth, we'll take Garth as our last question unless someone's got something very burning to say. Go ahead, Garth.
David, could you comment on what you would say would be the best exercises for maintaining muscle mass and preventing sarcopenia and improving bone mass with aging in simple terms?
Okay, so I mean, there'll be lots of everyone will have sort of preferences as to
Yeah.
how they want to be physical. You know, you might have someone who loves rowing or running. You know, running is probably the most popular sport on the planet. But there's a lot of downsides to doing monostructural activities. Okay, so just say you love swimming. There's fantastic benefits of swimming. There's fantastic benefits of running, but you only become a good swimmer. You only become a good runner. If I then ask you to pick up a heavy plant pot, you can't do it, right? So what's that fella's name? Kipchoge or whatever. He ran the marathon in some insane time, like under 2 hours. You know? But he probably wouldn't be able to open my garage door.
True.
So that doesn't make sense to me, because if you think about the musculoskeletal system and the health system, would you be happy to have really healthy lungs but a shot kidney? Would you be happy to have a good brain but a terrible heart? No. From a metabolic standpoint, I want my brain to be healthy. I want my lungs to be healthy. I want my kidneys to be healthy. So from a physicality point of view, I want to be able to lift some heavy things. I want to be able to move relatively quickly. I want to be able to reach up and grab things. I want to be able to jump if I need to. I want to be able to hang off a rope if I need to. You know, you don't know what physical things life is going to throw at you for the most part, especially if you're still working, and you know, especially if you've got a physical job. So in that regard, simply running or simply swimming or simply rowing wouldn't be my prescription. So that's where we come back to the physical concept of functional training or functional fitness. And functional fitness means that I'm kind of using multiple joints simultaneously. I'm using a lot of muscle groups at the same time, because they're compound movements. They maintain they express a high level of intensity, so you can't do them for very long. So when you do compound movements in functional training, your training sessions are actually pretty short. You know, you could go for a jog for an hour and a half and come home and still be talking to the missus when you get home. But if you do functional training, you can only probably go for about 10 or 15 minutes and you've got to stop and you're lying on the floor. Right? So that results in a different physiological stimulus. And if you think about functional training, you're kind of opening and closing your body. You're opening and closing your body. And I try to explain that to patients, like, imagine that you had a door in your house and you only open the door that much and squeeze your body around to go through. That would make no sense, right? We have these amazing joints that can move through amazing ranges of motion. We have hip joints that can allow us to squat down onto the ground. Yet how many people in their daily life activities ever allow their joints to express their full potential? Very little. And so these monostructural physical activities that people do, they're quite limiting. They're really quite limiting. And walking, you know, there's nothing wrong with walking, but I say to my mother and father-in-law, that's not exercise. I'm sorry, you may as well just stay at home and play Scrabble. Um, uh, that's locomotion. That's moving your body from A to B, but you cannot call walking with low intensity exercise. If you want to walk, see that hill over there that's 50 meters long, just walk up that and then come home and then continue watching, Oprah. Or see the staircase in your house. I know you're not very fit at the moment, but just walk up that staircase once every 3 hours for the day. Okay, because you can walk it up, you can walk up it, but just walk up it once every 3 hours, and then do it once every 2 hours, and then do it once every hour. And I can guarantee you that 30 seconds of walking up those flights of stairs will be better than your 1 hour casual stroll around the block.
Yeah, so variety is the key thing and a lot of different things.
Yeah, and compound movements. And if you tell me, if you want me to link you up with someone who can help you, if you're really serious about taking up some functional training, what city are you from?
Sydney.
Sydney. Yeah. I can put you in touch with someone.
Okay, thank you, David.
Hopefully they're geographically close to you, but if they are not, I'm sure they will be able to put you in touch with
Yeah,
someone.
I'm interested in general too, just for patients as well.
Yeah. As
a broader picture.
For patients, absolutely. You have it's life-changing. It's absolutely transformative. I think Svetlana wrote something there. Thank you so much for writing that, Svetlana. She says it's just transformed her and her husband's life in the chat there. But yeah, look, it was transformative for me as well. From going from size XL and high blood pressure and pre-diabetic to feeling, quite athletic and yeah.
And you've got your strength, like that's the key here, like being able to lift your body your body weight. I think that's really important. Like we've spoken a lot about that blue zone, which I know has been patented and taken over, but in its original form it was fantastic, like, and they give us so much advice, and follow that is what you basically spoke about tonight.
Absolutely. There's sustenance living, and also they're very happy. Their stress levels are very low. It's not a rat race in those blue zones.
You know why? Because they're able to be content, whereas us in the West and progressive countries, we're never content. We always want or achieve this goal. Next, what's the next one? We never enjoy our wins.
Publish one paper, I've got to start working on the next paper.
Yeah.
No, that's enough.
David, I think I can say on everybody's behalf, thank you so much tonight. It was a lot of fun, and I think I've got so many notes. You've really opened my mind up, and I'm definitely going to make some changes to my daily routine. You're right, the sitting, it's horrific. It's horrific.
Yeah, you bet.
David, thanks so much.
Thanks for having me on, and look forward to meeting all of you one day, maybe in the flesh at one of our.
For joining us tonight, and I'll send out a link for this recording too, so that you can share it with other people who you think should watch it, and if you want to watch it again, you're more than welcome to.
Good on you guys, and thanks for those nice comments on the chat there. That's really moving. Thanks so much. Okay, bye now.
All right, good night, everybody.